Oh hey Dr. Warko, I think I figured out this oral case presentation thing. I just saw a 65-year-old female. She's got a history of hypothyroidism, type 2 diabetes, and hypertension. She's coming in with progressive shortness of breath on exertion to the point where she's about New York Heart Association class 3 to 4, and she looks okay. She's not super sick, but she's got a little bit of workup breathing. I'm really most concerned that she's having decompensated heart failure, but there's potentially big concern for pulmonary embolism, and then maybe we can make a debate around potentially acute exacerbation of COPD versus an ACS versus less likely a pneumonia.
Okay.
So here's her story. So she's 65, has diabetes, hypertension, hypothyroidism, and for the last year she says she's short of breath when she's walking upstairs, gets better with rest. However, since returning from Australia last week, she's noticed that she's so short of breath that she can barely go to the bathroom before she has to stop to catch her breath. Other than that, her broad review of systems reveals the fact that she's endorsing orthopnea, P&D, and bilateral leg swelling. Doesn't really tell me a lot about weight gain, but to be honest, I didn't explore that as much as I should have. With respect to pulmonary embolism, like I said, she just came back from Australia, which is a fairly long flight, I think. Does have a cough, but isn't coughing up any blood. Doesn't endorse unilateral leg swelling. Hasn't had a PE-DVT before. Isn't on any hormone therapy as far as I'm aware. With respect to AE-COPD, she is a lifelong smoker. Does have a cough, but no change in her sputum. And isn't on any puffers at home, and hasn't really been diagnosed with COPD before. With respect to potentially an acute coronary syndrome picture, I mean, she's got a number of cardiac risk factors, so she's at the age range, she's a diabetic, she's a smoker, has hypertensive disease. As far as I'm aware, hasn't been risk stratified, but also something maybe for us to go back and explore with her. And then with respect to pneumonia, she hasn't really had any real fevers or chills at home, but like I said, has cough and a little bit of white sputum for what it's worth. With respect to her exam, on vitals, so she's tachycardic in the 120s, she's tachypnic in the mid-20s, and she's a little hypoxic at 91% on room air. When I look at her, she looks like she's in mild respiratory distress, but is in general quite well. Her exam is relevant for the fact that she's got no normal heart sounds, no murmurs. She does have decreased air entry to the bases and crackles throughout, and like I said, some intercostal indrawing and a little bit of tachypnea. She's got a soft belly, she's got a normal neuro exam, and like I said, she's got bilateral pitting edema to the shins, no unilateral leg swelling. For the investigations that we have thus far from triage, they're grossly normal. She's got a mild leukocytosis with a white count of 12, and of relevance, actually a normal creatinine, which is reassuring. Her EKG showed sinus tachycardia with no obvious signs of ischemia that I can see, and no signs of right heart strain. And that's all we have so far. So, in summary, I have a 65-year-old female with progressive shortness of breath on exertion to the point where it's affecting her basic activities of daily living. My biggest concern with respect to workup is heart failure, and I think she warrants a chest x-ray. And I wouldn't mind your help going in the room and just performing a bedside echo just to see what her ejection fraction is doing.
Okay.
Similarly, my other big concern is pulmonary embolism. With respect to PE, if you calculate out her Wells score, I got a moderate, and so we can debate, but I think she would warrant a CT pulmonary angiogram to rule out PE, especially because I don't have an obvious trigger for her heart failure. With respect to an acute coronary syndrome perspective, she could present atypically, is my understanding, because she's an elderly lady who has diabetes, and so I think I would add on a troponin at the very least to her blood work. If all else fails as part of our workup, I think that if we're not going to diurese her, and we want it, and you think she might have an AE-COPD, then we can make an argument then potentially to do a pre and post spirometry and do some bronchodilation on her. And then for the least likely option of pneumonia in my head, we're still getting the chest x-ray, so that'll help answer that question. For her symptom relief, she is short of breath, and she's beginning to get hypoxic. I would actually like to diurese her empirically.
Okay.
And so I was thinking some amount of furosemide, but maybe you can help me figure out a good dose for her.
Sure.
And then as for, is she going to go home or is she going to get admitted? I think that's a little bit dependent on how well she responds with respect to diuresis, or if we end up going the route of bronchodilators. She's 65 and lives independently, so she's someone I want a little bit doing really well before she goes home. So that's this patient. I don't know what your thoughts are on her.
Okay. I think that sounds like a good start. Why don't we start with some diuresis? Maybe we can give her 40 milligrams of furosemide to start with and get the chest x-ray, add the troponin, and we'll reassess after that.
That sounds like a great plan. Thanks so much for listening.